Feel free to introduce yourselves in the chat box. Let me know, are you a nursing student? Do you have a background in the medical field? What are your goals for today, learning about adult health and the GI system? Go ahead and answer anything that you feel like. And I'm just waiting for a few more participants to join us. I'll give it a couple more minutes here and then we'll get started. New grad and prepared to take the NCLEX. That's exciting. You're going to do great because you're here and you're preparing yourself. So I know you're going to do amazing. I'm going to go ahead and start sharing my screen with you guys so you guys can see my presentation here. Hi, Nubia. Hi, Justine. We're going to be having lots of webinars talking about different topics that are on the NCLEX. We're going to be helping you prepare here. So stay posted on the website to see what different topics we're offering every week. So I'm going to go ahead and get started here, and we'll go kind of slow in the beginning to give everyone a chance to join. But I'm going to go ahead and get started with the presentation. I'm going to make it nice and big for you guys. Hopefully you guys can see well. If you can't see it, let me know. And feel free to drop any questions in the chat box during the presentation. If you have any questions, you want me to clarify something, if you want to intercept and I'm going too fast, let me know. But today we're going to be talking about gastrointestinal disorders. Not all of them, some of them, some of the important ones. And here's a bit of a little overview of what we're going to be going over. First, I'm going to do a little introduction for you guys, tell you who I am. Then we're going to go over peptic ulcer disease, also known as PUD, as well as GERD. We're going to go over Crohn's disease, ulcerative colitis, hepatitis, and some NCLEX strategies and practice. These are some pretty comprehensive diseases of the GI system. Some of them, like hepatitis, there's so many different types, it can get a bit confusing. And then when it comes to certain diseases like PUD and GERD or Crohn's disease and ulcerative colitis, they can be a little bit similar and difficult to tell apart. So we're going to talk about those and hopefully clear up some doubts that you guys may have. And I'm always kind of keeping my eye here in the chat. Very clear from Kenya. I'm Wilson. Hi, Wilson. I'm glad to see my screen is clear and that you guys can see. Let me know, and I'll work with you guys in any way that I can, okay? So first, I want to tell you about me. My name is Maria. I'm an RN, and I'm also an NCLEX prep educator. I'm really passionate about helping to make tough topics simpler than they should be, and clinical and test ready. Like, how do we apply these topics in the clinical setting, and how do we apply them to the test, right? Like, how do we answer questions about these topics? So we're going to go over some questions at the end and practice together. I have 8 years of experience in the medical field. I've worked in many different areas. I've worked in behavioral health, emergency care, progressive care, infusion nursing, and also maternal newborn. So I have a wide-based knowledge of different areas in nursing. And I'm really excited to welcome you to today's session on hepatitis and the NCLEX. Today we're going to break down the 5 types of viral hepatitis, A, B, C, D, and E. Kind of easy to remember in that order, right? And then we're also going to talk about how they're transmitted, diagnosed, and treated. We're going to talk about nursing interventions, patient education, and prevention strategies. And of course, we're going to go over some NCLEX style questions with test taking tips that you can use right away. Now, whether you're learning this for the first time or you're reviewing for your board exam, this session is designed to help you with clarity, confidence, and clinical context to help you master all of these different topics on the NCLEX and in real life. So let's go ahead and dive in, and then don't forget to jump into the chat so that you can answer our icebreaker question, which is, what GI topic is the most challenging for you to understand or remember? I'll share for myself. For me, I would say it's all the different types of hepatitis were challenging at first for me to remember and to kind of differentiate between them. There's so many different types that it's hard to remember. Like, is it transmitted by blood? Is it the fecal oral route? Like, which one is it? So let me know in the chat. And while you do that, I'm going to start by talking about just a general overview of the GI system. We know that the GI system is responsible for digestion, absorption, and elimination of nutrients and waste. Digestion is obviously when we consume food and our body needs to break it down in order to absorb the nutrients, which is absorption. And then we eliminate the excess waste from what we absorb, which is the elimination. It starts at the mouth and ends at the anus, and it has lots of accessory organs in the middle playing vital supporting roles. So, the major organs and functions of the GI system are the mouth, which begin digestion via chewing, and salivary enzymes. So, when we start chewing our food, that's already the beginning of the digestive process. We chew it with our teeth, we break it down, and then our salivary enzymes come into the food that's been chewed up and start already to break down that food. And then our food goes down into the esophagus, which transports food via peristalsis to the stomach. Peristalsis is the movement of food down from your mouth into your GI organs. The stomach breaks down the food with acid, also known as hydrochloric acid, and pepsin. And then we have the small intestine, which is a primary site for nutrient absorption. We have the duodenum, the jejunum, and the ileum, and I'll show you a picture here. Let's see. Here's a good one. So that's the duodenum. You can say it like tomato, right? Duodenum, however you like it. The jejunum and the ileum right here. So those are parts of the small intestine. And the large intestine, which is the big one over here. And again, this is just a really small overview. I'm sure all of you guys already know this, but it's always nice to have a little refresher. The large intestine absorbs water and forms the stool. And the rectum and the anus is the storage and elimination of feces. So that's where it's a big muscle group where everything gets squeezed out of the body and eliminates all the waste. We have some accessory organs here, like the liver. The liver is really important. It metabolizes drugs. It produces bile and stores glycogen to help break down fats. The gallbladder assists in that by storing and releasing bile to digest fats. And the pancreas, this little yellow one right here, produces digestive enzymes and insulin. We know the pancreas has a huge role in diabetes. Now, some NCLEX tips here about the GI system. If it's inflamed or obstructed, expect pain, nausea, and altered labs. Those are some of the main symptoms. When it comes to the liver, you always want to look at AST and ALT numbers on your labs. The pancreatic enzymes, lipase and amylase, are very important to remember. We know that bilirubin has to do with bile flow, and we also know that we need to always monitor for bleeding, infection, and fluid electrolyte imbalances. That's just a small overview here of the GI system. And I'm seeing some answers here: Crohn's and diverticulitis, intussusception versus volvulus, diverticulitis, peptic ulcer disease, pancreatitis, and appendicitis. Yes, these are all really complex conditions. that can be really challenging to understand. I completely agree with you. I love that you guys are interacting. I appreciate that. All right, let's go to the next slide here. So now we're going to start by talking about peptic ulcer disease, which is defined as the condition where open sores, also known as ulcers, form in the lining of the stomach or the duodenum, often due to acid and pepsin erosion. So something breaks down the tissue inside the lining of the stomach, and it tends to cause ulcers. As far as the pathophys goes, it's the breakdown of the protective mucosal barrier, and acid and pepsin damage the epithelial tissue. So if there's a lot of acid there and the mucosal barrier that protects the stomach starts to break down, it could damage the tissues in there. Now, healing is impaired when the damaging factors outweigh the mucosal defenses. So, just like everything else in the body, if your body's defense systems get overwhelmed, it can no longer protect you. So, it can't heal itself when there's too many damaging factors and not enough mucosal protection in the stomach. So, some of the causes of PUD, peptic ulcer disease, are H. pylori infection, also known as the Helicobacter pylori. And the H. pylori can actually damage the mucosal lining, also causing peptic ulcers. Another really big reason that's not talked about as much is chronic NSAID use. So, the drug class nonsteroidal anti-inflammatory drugs, kind of like Motrin, ibuprofen, aspirin. Those drugs actually damage the stomach lining. They inhibit prostaglandins, which cause decreased mucosal protection in the stomach, which can overuse and over time can cause peptic ulcers. So it is something that we need to educate our clients on. And we also need to be aware of their previous medical history and make sure that when we are educating them on the use of NSAIDs, that if they already have a history, of peptic ulcers, that we are letting them know this is a risk factor. And another etiology here is gastric acid hypersecretion. So it can be caused by Zollinger-Ellison syndrome, or the majority of cases is actually from stress, right? So we talk about when patients are stressed, typically in the hospital, as part of like your general standard orders for most patients, they'll give you a PPI or a proton pump inhibitor, just to make sure that during your stay in the hospital, when there's a lot of stress, that you are not developing a peptic ulcer. So being stressed chronically for a long period of time can cause hypersecretion of gastric acids, which can erode the stomach lining. So remember, NCLEX tip here is any patient with ulcer symptoms, always test for H. pylori. I'm going to check back here, see if you guys have any questions for me. I see some more topics here that are challenging: ulcerative colitis, Crohn's and dumping syndrome, and then IBS versus IBD. Yes. All right, let's go on to the next slide here. So some risk factors for peptic ulcer disease. Some contributing factors are smoking, which can increase stomach acid and decrease the mucosal defenses. That's just a combination here that leads to chaos in the stomach. If you have decreased defenses but increased acid, the tissue is definitely going to be weakened and more vulnerable to damage. Alcohol irritates the gastric lining. So especially if somebody is combining, if we know this patient has, a history of consuming alcohol, more than just the normal social consumption. Maybe they have an overconsumption of alcohol, and maybe the next morning they take medication. Maybe they take NSAIDs to cure their headaches, or because they're feeling sick the next day. then, now we're combining two really serious risk factors here, which are alcohol and NSAIDs, and the stomach is definitely going to be at risk of developing peptic ulcer disease. Stress can definitely worsen the symptoms. It's not a direct cause, but it's definitely up there. It's something that's directly correlated and associated with it. So it's very important to educate our patients, and also first to assess to see if they have a stress management routine. If they are a client that's suffering from peptic ulcer disease, it's important in their recovery and their clinical management that they have a stress management routine, so that it doesn't worsen their symptoms or hold back their recovery. Also, spicy and irritating foods can aggravate the pain. They don't cause ulcers. That might be some kind of a misconception. Maybe someone may have told you in the past eating spicy stuff can cause ulcers. They don't. However, it can aggravate the pain because of the capsaicin, which is the spicy compound in peppers and such. But it can be lots of different spicy or irritating foods that can actually trigger pain when you do have a peptic ulcer. Another risk factor is family history or chronic illness. And an NCLEX tip here is to always assess for NSAID use and lifestyle risks in patients with GI pain. And of course, educate always. Let me know if you have any questions or if I'm moving too fast here. And then we have some clinical manifestations of PUD here. We have a burning, gnawing epigastric pain, often worse on an empty stomach. So if, our client's telling you like, oh, every time I don't eat for a couple hours, my pain gets worse. Typically, if the pain is worsening with food, it's more likely to be a gastric ulcer. Whereas if it's relieved by food, it's likely to be a duodenal ulcer. So the ulcer can be in different places in the stomach, and that will typically tell you, they'll be able to see that with diagnostic imaging, but it will be able to tell you how to treat it, right? How do I treat this? And what different reasons or different symptoms are showing up to tell me what it is most likely. Is it a gastric ulcer, or is it a duodenal ulcer? Other symptoms are bloating, nausea, and vomiting. Again, these are not very telling symptoms, but they are associated with it. Bloating, nausea, and vomiting can definitely come from different conditions too. So it's always important to assess and do imaging and do labs and, see what's really going on with your patient here. But bloating, nausea, and vomiting is associated with PUD as well. And based on pain-related eating patterns, there may be weight loss or weight gain. Now, ulcers may present as silent in older adults or those on NSAIDs. So like I was talking about, let's say your patient has fibromyalgia and they are prescribed, ibuprofen. Take ibuprofen 600 every day, 4 times a day. And sometimes they may develop an ulcer without even knowing from the chronic use of the ibuprofen. And at some point, that can progress and become worse, and they will never realize why it happened in the first place. So that's why it's important to always look at past medical history and, look at our patients as a whole and provide education based on that. Let me see if you guys have any questions here. I see some more conditions here. Celiac disease. Hi to the Philippines. All right, moving on here to the next portion. So let's talk about some diagnostics, some essential diagnostics for visualizing a peptic ulcer are upper endoscopy. This is a direct visualization of the ulcer, and they're able to gather a biopsy at the same time. Basically, the client will be put on a bed, they will be sedated, and they will have a tube put down their throat into the stomach. It's a scope that has a little camera at the end and is able to see what the lining of the stomach looks like on the inside. If they see, abnormalities in there, they'll take pictures. And then they will be able to biopsy it as well to make sure that there's no malignant process going on in there. Another diagnostic here that we can do is H. pylori testing, which is a breath test. They're basically doing a urea breath test. That's pretty common for anyone who's experiencing the symptoms that I mentioned earlier. Oh, I'm having stomach pain with or without food. I'm having nausea, bloating. Let's go ahead and get an H. pylori test done and rule that out. Also, a stool antigen test can be done. And then, of course, like I mentioned, a biopsy during the endoscopy. The stool antigen test would require a stool collection, of course. And barium swallow is another diagnostic exam. It's less sensitive, but it may detect some ulcers. And CBC is just something we also like to do on the side. If we know that this person is having GI distress, the CBC can tell us, are they becoming anemic? Is there any GI bleeding suspected? We can also tell if there's GI bleeding from different assessments as well, like looking at their stool. But checking the CBC is always a great addition to the imaging as well. And an NCLEX tip here is to prioritize endoscopy for a definitive diagnosis of an ulcer, especially when we're having red flag symptoms. Let's see here if we have any questions so far. Let me know if you have any questions. Is PUD a risk for stomach cancer? That is an excellent question. I am going to talk about that. Actually, H. pylori is definitely a risk factor for stomach cancer. So, depending on the etiology of the PUD, like is it H. pylori or is it caused, by stress and like drug overuse, it can definitely be a risk factor for stomach cancer. So let's talk about, that's a great question, by the way. I love the questions, keep them coming. Let's talk about some management here. So we know that there's always pharmacologic and non-pharmacologic strategies to take care of, the issues that our clients are going through. So proton pump inhibitors, also known as PPIs, are kind of the first line defense when it comes to PUD. There's different options for this one. What they do is reduce acid production. Now, there's always risks, as with any medication, there's always going to be risks. So it's really important that we educate our clients on the medications that they are taking. So with proton pump inhibitors, taken over a long period of time can decrease stomach acid, which can affect digestion over time. And it can also put the client at risk for C. diff infection. So, it's important to educate our clients on the risks, but we know that physicians are, prescribing and administering these medications because the benefit and the reward is greater than the risk at the time. So these proton pump inhibitors should not be taken very long term, but they are an excellent choice when it comes to kind of lowering that stomach acid production for a while, which typically can take around 3 months while that ulcer is healing. And after that, then we do lifestyle management. H2 receptor antagonists, such as famotidine, also known as Pepcid, a very common medication given. And then we have antacids, which are just a quick symptom relief. These aren't going to cure the problem long term. They aren't going to, help to actually manage the condition, but they can give a quick relief, like taking Tums when they are experiencing a lot of like burning or pain. For H. pylori, we would be giving out antibiotics. Typically, what they will do is something called the triple therapy, which is a PPI, clarithromycin, and amoxicillin, or metronidazole. And then we also have cytoprotective agents like sucralfate. So this one is actually kind of like a coating agent that will coat the stomach lining and protect the ulcer base. So it will kind of protect the stomach lining. It will create like its own coating over the stomach while the stomach is healing. So that's an excellent choice as well. Now, an NCLEX tip here is eradicating H. pylori is essential to prevent recurrence. So that means we have to teach our patients to adhere to their entire antibiotic course. Some non-pharmacological strategies, which are also some lifestyle management strategies, not only during their treatment, but also after, in order to prevent recurrence, are to avoid NSAIDs if we know that they have an existing history of GI problems. Switch to acetaminophen or Tylenol, paracetamol when possible. To stop smoking so that we can stop damaging that tissue in the stomach, to limit alcohol, caffeine, and irritating foods, to eat small regular meals so that the stomach is not having a really hard time digesting and overproducing acid to break all that food down. And also to reduce stress, such as behavioral therapy or relaxation techniques. Like I talked about, stress management is important, and it's so important to see our patients as a whole. Like I talked about earlier, patient teaching, it's really important to emphasize adherence the entire antibiotic course for H. pylori, because eradicating it will prevent the recurrence, and also having other lifestyle management strategies like I talked about. Let's see if we have any question here. Between endoscopy and H. pylori, which test is definitive? I thought it's H. pylori since it's less invasive. So the reason why they do endoscopy is because we want to know if there is an ulcer, like where it is, what it looks like. They usually want to biopsy it. So that's a definitive diagnosis that there is a peptic ulcer, right? And the H. pylori breath test is just going to detect the presence of H. pylori. Doesn't necessarily mean that there is an existing ulcer in the stomach. Triple therapy for how long? It kind of depends on the patient. It can take, some antibiotics can take a couple of weeks to 21 days to take, but they will typically have the patient on the PPI for the proton pump inhibitors for around the time of like 3 months or so. And yes, endoscopy is the best. I completely agree with that answer. Excellent questions. I love that you guys are asking questions. Keep them coming. So let's talk about some complications here and why it's important to have early interventions with GI problems. And the reason why is because let's say that ulcer, is so bad, the tissue is so damaged that it's starting to cause GI bleeding, right? So if that patient is having GI bleeding, they could be having one of two things or both. They could be having hematemesis, which is vomiting blood. Typically, the blood could come out as, if it's been exposed to the gastric acid, which oxidizes hemoglobin, like it says in the picture, it can come out as looking like coffee grounds, right? And then you can also have melena, which is when there's blood in the stool that's been through the GI tract, so it contains partially digested blood. And once you're in the clinical setting, some of you may already have experience with this. If you're already nurses or you're already CNAs, or if you've been in a clinical setting and you've had a GI patient, it's typically very apparent when they have a GI bleed because there's a certain smell to the stool. And the stool, like I said, it's very tarry. It has a different consistency, but typically when you walk in the room, you can already smell when it's a GI bleed. Perforation is a very serious complication. It can cause sudden severe pain and a rigid abdomen, which is a surgical emergency. So let's say that ulcer damages the tissue so badly that it perforates, and now stomach acid can, come out and leak into the peritoneal cavity, and it can cause sepsis. So this is a medical emergency. It's an immediately life-threatening emergency. If you have your patient in the clinical setting, they have an ulcer, they develop sudden severe pain, and their abdomen is rigid to the touch, you immediately contact a physician. And of course, GI bleeding can cause anemia and hypovolemic shock. So we want to make sure that we are taking care and having early intervention, all of these complications, and paying attention to our assessments of our patients so that we're in touch with what's going on with them. Another complication is the gastric outlet obstruction, which is vomiting undigested food and bloating. So, if the stomach acid imbalance is going on and they are vomiting undigested food, they can have an obstruction. And then we also have increased gastric cancer risk, like we had that question earlier, especially with chronic H. pylori infection. Now, the NCLEX tip here is if there is sudden, sharp pain, distension, and hypotension, you most likely have a perforation. Call your provider stat because that is a life-threatening emergency. Let me know if you have any questions. Yes, the recording will be available, I believe. I'm going to have to figure out a better answer to that, but I will let you know how to access the recording after the lecture. Is smoking nicotine a problem? Yes. Definitely a problem. It's not just the nicotine, it's the act of smoking, right? And also there's lots of other chemicals when it comes to smoking, but just the combustion of smoking alone is introducing a lot of chemicals into the body, and just that whole process can affect and damage the stomach lining. Is milk contraindicated? I believe it's contraindicated to drink milk when you're taking that medication at the same time. And I do believe that it blocks the absorption of the medication. Thank you so much, Susan. I appreciate it. Yes, so we see here the recordings will be uploaded in the Naxlex website, NCLEX RN app, and web browser. So you guys can definitely access the recording. So let's talk about GERD, also known as gastroesophageal reflux disease. And the pathophysiology and etiology here is defined as a chronic condition where the stomach acid flows backward into the esophagus, irritating its lining. I think everybody's had this before, or to some degree. It's, we also call it heartburn, right? We feel a burning feeling in the chest. We feel kind of the acid coming up into the mouth. It's caused by a dysfunction of the lower esophageal sphincter, which is also called the LES. The sphincter is a muscle that kind of opens and closes here, and that keeps the acid in the stomach. So when there's a dysfunction of the LES, it allows the gastric contents to reflux and come up. An acid exposure can damage the esophageal tissue over time, right? So the esophagus, where the food goes down into the stomach, is not meant to have acid coming into it all the time. So once it's getting exposed over time, that tissue could get damaged. So when we have weakness or relaxation of the lower esophageal sphincter for different reasons, that can be the primary cause. And one example of that is when women are pregnant, they have a hormone called relaxin that kind of causes everything in the body to relax and loosen up. And it can cause the sphincter to kind of open up more. And that's why a lot of pregnant women get heartburn towards the third trimester. Can also be caused by delayed gastric emptying and increased intra-abdominal pressure, such as obesity or pregnancy. Again, another reason why in pregnancy, a lot of women tend to suffer from heartburn or GERD. So an NCLEX tip here is GERD is a common cause of chronic cough or unexplained chest pain. But it's always important to rule out cardiac causes first, right? So if we have a patient coming in, sometimes in the ED, they can have symptoms similar to a heart attack or an MI, and they're having chest pain, they're feeling anxiety, they're feeling a burning feeling here. And of course, we're going to go ahead and monitor their cardiac status first to rule out that it's not a cardiac cause. But typically, it tends to be just heartburn or a GERD attack. And so giving them a GI cocktail will tend to soothe that. And then, of course, doing imaging and diagnostics and seeing what's the cause of it and how we can manage it. But having GERD can also be a cause of chronic cough, as it says, and it can also be a cause of a bit of like throat congestion. And again, because it's damaging that tissue in the esophagus. There's some risk factors here for GERD, and some of the major risk factors are obesity because of increased abdominal pressure, a hiatal hernia, which alters stomach positioning and weakens the LES. The LES, again, is the lower esophageal sphincter. And a lot of people can have hiatal hernias throughout their life and never know that they have that until they start to have symptoms of GERD. Pregnancy is another risk factor, such as the hormonal effects, like I talked about, the relaxin, as well as the pressure from a growing uterus pushing up on the stomach. Smoking and alcohol, they can relax the LES and increase acid. And dietary habits such as fatty, spicy foods, caffeine, chocolate, citrus, and large meals. These are the things that we tend to tell our clients not to consume while they're healing GERD or peptic ulcer disease. Now, remember, an NCLEX tip here is to prioritize education on lifestyle changes to reduce reflux episodes, right? So we're going to educate our clients on, of course, we're educating them on the medication they're taking and their treatment plan, but we're also educating them, hey, here are some lifestyle changes that you can make in this meantime so you don't have a recurrence of this problem. And so that also you can reduce the episodes that you're having. Now, some common symptoms as a clinical manifestation of GERD are heartburn, right? That's the most common one that mostly everyone experiences. And it's when someone is having post-meal chest burning, right? Maybe they ate a large meal, or maybe they ate something that was more acidic, like they had some orange juice in the morning. Or, in the evening, maybe they had pizza, which has tomato sauce, and the cheese is very oily and fatty. So those things can trigger GERD to worsen and to exacerbate. So they can have really bad heartburn from those things. Also, it can be a positional thing. So regurgitation, let's say they're eating and they lay down to go to sleep right afterwards. That positioning is going to cause that acid to back up, more than it would have if gravity was helping. So that's when acidic fluid goes into the throat or the mouth, and it's regurgitation. And they can also have difficulty swallowing, also known as dysphagia, and a chronic cough, sore throat, or hoarseness. And that's because the acid is constantly irritating the esophageal tissue. So an NCLEX tip here is symptoms can be worse when lying down or after eating a very large meal, right? Or just for some people who have it really bad, it can be just after any meal that's, it's like a normal size meal can even trigger it at that point. And at that point, we know if our patients are displaying these symptoms that we want to use some diagnostic tools here, right? We want to assess our patients to see exactly what is going on so we can treat it appropriately. So their clinical evaluation is going to be based on their history and their symptoms. So they're telling you, I'm having burning after I eat. It's triggered more by certain foods. I can't even lay down at night after dinner. And then we're going to see, those are their symptoms. And then maybe they're going to tell you, hey, like I have a history of smoking and overconsumption of alcohol, things like that. We're going to combine, we're going to look at the whole picture. And the diagnostic here, besides a clinical evaluation based on history and symptoms, is going to be imaging, right? So we're going to do an upper endoscopy, just like with the peptic ulcer disease. This can visualize the esophagus and detect if there is any structural or tissue damage. We also going to do some esophageal pH monitoring, which measures the acid reflux frequency, and esophageal manometry, which assesses the LES tone and the esophageal motility. Now, an NCLEX tip here is pH monitoring is the most accurate test for GERD diagnosis, but I'm going to be honest with you and tell you that for the most part, physicians diagnose GERD based on the symptoms and the history. Now, for management of this condition, we have pharmacologic treatments and lifestyle modifications, right? As always, we want to do kind of a whole approach a whole person approach to treating our patients and to helping them manage their conditions. So some lifestyle modifications, weight loss might be recommended if the patient is overweight, and we know that excess weight is contributing to the compression of the stomach. They might recommend weight loss. They might recommend exercise, which may have other positive benefits for the patient as well. Although this isn't the only treatment, right? There's going to be a lot of other things. So one of the easiest things that the patient can do is to elevate the head of the bed. So about 6 to 8 inches. So, prop themselves up with pillows a little bit more at night, so that they're not laying down flat. And that positioning can be a very simple yet very effective intervention. Avoiding meals 2 to 3 hours before bed, right? Because we're going to sleep, we're laying down, those things can all be triggers. The stomach is relaxing when we're going to sleep, right? So we want to avoid meals too soon, right before we're going to bed. We want to give it a couple of hours at least. And we're going to limit triggering foods, right? It's good for the client to have a self-assessment. Maybe they can even keep like a nutrition diary of what they're eating throughout the day and seeing what are their trigger foods, right? We have standard trigger foods, which are, like I said, tomatoes, citrus, coffee, alcohol, things like that can all trigger GERD and peptic ulcer disease pain. However, for each person, one food may be more triggering than the other. So keeping a food diary would be really, really helpful to them. But again, acidic, fatty, spicy, and caffeinated are kind of the biggest categories of the food offenders. Now, for pharmacologic treatments, antacids can give quick symptom relief, like Tums, and H2 blockers like famotidine, Pepcid can reduce acid. PPIs like omeprazole and pantoprazole can give long-term acid suppression, although, like I said, there are risks associated. And then we have prokinetics such as metoclopramide, also known as Reglan. It can help with stomach motility. And of course, depending on the client and on their symptoms and on their lifestyle, each of them may get a combination or different medications administered or prescribed to them to manage their condition, because everyone is unique and individual. But an NCLEX tip here for you is that PPIs, proton pump inhibitors, such as pantoprazole, also known as Protonix, PPIs are the most effective acid suppressing therapy and also the ones that are used most often. And they are pretty low side effects, with the exception of the long-term risks that I mentioned earlier. There are also surgical management options for these clients. And there's also some complications of untreated conditions that we're going to talk about. So some surgical interventions here, the most common one is called the Nissen fundoplication. And it's when they wrap the stomach around the lower esophageal sphincter to reinforce it. So there's a picture here. They kind of open up a little piece of the stomach and they wrap it around the LES to kind of reinforce it and give it a bit more structural protection. And this can be done in refractory GERD or with the hiatal hernia. And there are some complications if GERD is left untreated. Of course, we're going to have inflammation of the esophagus because there's acid constantly coming up, also known as esophagitis. And we can also have esophageal stricture, which is narrowing from scar tissue. Now, this is a bit more dangerous as a complication, right? So we're going to have narrowing of the esophagus because there's so much damage to the tissue inside that scar tissue is building up. We also have Barrett's esophagus, which is metaplasia of the esophageal lining. And esophageal adenocarcinoma has a very increased risk with chronic Barrett's esophagus. So we know that there is a risk for cancer when it comes to GERD, being left untreated and there just being so much tissue damage being done constantly and nothing being done about it. So the NCLEX tip here for you is Barrett's esophagus is a precancerous condition and it does require long-term monitoring. So again, as always, safety comes first and early intervention is key to treatment. Let me know if you guys have any questions. Drop them in the chat box. I'm looking out. And let's see here. Our next topic is going to be hepatitis. All right. So let's talk about the pathophys and etiology of hepatitis. We know that it's an inflammation of the liver. The liver is located in the right upper quadrant of the body, and it is a vital organ in our GI system. And hepatitis is often caused by viral infections, although toxins, alcohol, and autoimmune conditions can also contribute. So we have 5 different types here that we're going to be talking about. Hepatitis A, B, C, D, and E. So hepatitis A has a fecal oral transmission and it's acute only, meaning it lasts a short period of time, and then we have treatment for it, and then that person no longer has it. We also have hepatitis B, which is it has a transmission route of blood and body fluids. So this can be obtained through the use of shared needles. It can be obtained through sexual relations, and this condition can be chronic. Hepatitis C is also often chronic, and it is bloodborne. So if you have blood exposure. Hepatitis B requires HPV co-infection, HBV, not P. And hepatitis E is a fecal oral transmission, and it's extremely dangerous in pregnancy. Now, it's important to know which types have vaccines, which is A and B, and which can become chronic, which is B, C, and D. Let's talk about transmission and some risk factors here. So, as we said, the transmission routes are very important to know to differentiate each of the types of hepatitis. So, hepatitis A and E has fecal and oral transmission. So, that means contaminated food or water. So, if there's a food worker and they use the restroom, they don't wash their hands properly, and they go back to preparing the food and they have hepatitis A or E, that means that if you consume that food, there will be a fecal oral transmission and you will now, suffer the symptoms of hepatitis A or E. And as far as hepatitis B, C, and D, those are bloodborne transmission routes, and they can come from IV drug use, sharing needles, sexual contact, unprotected, or perinatal. And that would mean if mom has, one of these conditions, then baby has a high risk of contracting it, which is why they give babies hepatitis B vaccine at birth. Let's talk about some risk factors. So unprotected sex is a very high risk factor for hepatitis B. For hepatitis C, it's needle sharing and pre-1992 blood transfusions, but not anymore, thankfully. For hepatitis A and E, poor sanitation. So we know that that's fecal oral, so that means, people aren't washing their hands, they aren't washing their cutting boards, they aren't washing their kitchen utensils. Very scary. HEV is pregnancy is a risk factor, and being a healthcare worker. So pretty much all of us here, right? We're nurses and doctors, CNAs, respiratory therapists. Like we're all being exposed to bodily fluids and to patients that may have infections known or unknown. And needle stick injuries are the highest risk factor for that, especially for B and C. Now there's a little mnemonic here to help you remember: A and E from the anus, B, C, and D from the blood. And we have some clinical manifestations here for acute and chronic symptoms of hepatitis, and they are pretty similar all across the board here. And it's going to be fatigue, malaise. Malaise means not feeling well, right? Just a general feeling like, oh, I don't feel well. I feel like really bad. Anorexia, which is not eating. nausea, vomiting, right upper quadrant pain, right? So right here, right upper quadrant, right below the right breast, and kind of, near the ribs. Jaundice, which is a yellowing of the skin and the eyes, and that is due to the buildup of bilirubin because the liver isn't able to process, because hepatitis is happening in the liver. Dark urine and clay-colored stool can be classic signs of hepatitis, and itching due to the bile salt accumulation, which when you are taking clinical notes and charting, it's going to be charted as pruritus. And the NCLEX tip here is symptoms of jaundice, dark urine, RUQ pain, which is right upper quadrant. These are all red flags for liver involvement. So if you have a patient, a case study, a question that's like, this patient's coming in with yellowing of the eyes and skin, they're complaining that their urine is really dark, and they're complaining of pain, behind the right rib, what diagnosis are you immediately thinking of? It's going to be liver involved, most likely. All right, let's talk about management. So for acute hepatitis A and E, which again is a short-lived infection, there's not really anything we can do to quote unquote cure it, but we can provide supportive care, right? Kind of like the flu. You can't cure the virus, but you can provide supportive care, which would be rest, hydration, and avoiding hepatotoxins, right? So these are things that are toxic to the liver, such as alcohol, such as medications that are excreted through the liver. So these are just going to be the most important interventions here: rest, hydration, and avoiding anything that's going to further exacerbate the liver and prevent it from healing itself. For hepatitis B, we have chronic cases that are treated with antivirals, right? So we have some antiviral medications that those patients are going to have to take for a little while to treat that virus. And a very important intervention here with hepatitis B is we need to monitor for cirrhosis and liver cancer, right? Sometimes people may contract the infection earlier in life and they may develop cirrhosis at that time, or they may develop cirrhosis later in life, which is also really scary. Hepatitis C, we have direct-acting antivirals, also called DAS.
Yeah,
And these
we can't really see the slide. I think somebody interrupted it. One Tolu or something.
Sorry, say that again.
Someone interrupted the slide. Okay, yeah, we can see now.
You see it now? Thank you so much for letting me know. I appreciate that. Were you guys able to see the last slide, or was it just this one that got interrupted?
It's just this one. We couldn't see the last slide.
Oh, should I go back for you guys? I'll go back just in case.
Yes.
Yes. Thank you for letting me know. I appreciate that. So this was the last slide, and I'll just do a small overview here. It was just about the clinical manifestations. We have acute and chronic symptoms here, depending on which type of hepatitis the patient may have. But the general symptoms are fatigue, not feeling well, not eating, not having an appetite, nausea and vomiting, pain in the right upper quadrant, jaundice, which is again the yellowing of the skin and the eyes, dark urine, stools that are clay colored, and a lot of itching because bile salts accumulate in the skin because they're not being processed properly by the body, right? And I was giving you guys a tip for the NCLEX. If a patient comes in with yellowing of the eyes and skin, complaining of dark urine and pain in the right upper quadrant, these are immediate red flags for liver involvement. So I'm going to go ahead and move on to the next slide. If you guys need to see it again, let me know. And this one, I was just talking about the management of the different types of hepatitis, which for A and E, it's supportive care only, rest, hydration, and avoiding any toxins that may further exacerbate the liver while it's healing. For hepatitis B, we have antivirals, and monitoring for cirrhosis and liver cancer is very important. Again, early intervention is key here. And we have for hepatitis C direct acting antivirals, And they have a 95% cure rate, which is actually amazing, right? And there's no vaccine available for hepatitis C, but the medication is pretty effective. And for hepatitis D, the underlying HBV virus needs to be treated, and it may also require antivirals. Now, a tip for the NCLEX here. Hepatitis C is curable, but hepatitis B is not, right? So we need long-term management. And again, like I said, a patient may have hepatitis B at one point because it is a chronic thing, they will continue to have it, but they can be managed, right, with the antivirals. And we really want to make sure to monitor for cirrhosis and liver cancer because damage can be done to the liver over time. And some prevention strategies here. There are vaccinations available for types A and B, and they are effective. So it's really important, especially if we know that the client has a high risk for getting that disease, right? Maybe they're traveling somewhere where we know that there's poor sanitation, or maybe we know that they're, in an area where there's a lot of people that are infected with hepatitis, right? Maybe they're a healthcare worker. So it is really important to have vaccination as a prevention strategy. And also for hepatitis E, there is a vaccine available in some countries, but not in the US. And most importantly, and I think this is, really the number one strategy here is standard precautions, right? We want to make sure that we're doing proper hand hygiene, that we're using PPE, our protective equipment, and that we're doing safe injection practices to prevent, accidental needle sticks as healthcare workers. Also avoiding raw or contaminated foods. Obviously, we don't know what foods are contaminated, right? But sometimes we hear about recalls and outbreaks. Sometimes, we know that some raw foods can be prone to having a different, microbial infestations on them. So it's important to avoid those. And screening blood products, right, to prevent hepatitis C. And then, of course, if somebody has been exposed, PEP, post-exposure prophylaxis. If somebody has been exposed to hepatitis B, having the hepatitis B immunoglobulin plus the vaccine can be an effective strategy here. But there is no post-exposure prophylaxis for hepatitis C or A, unfortunately. And an NCLEX tip here is healthcare workers that are exposed to hepatitis B should receive HBIG and the hepatitis B vaccine within 24 hours. So let's say there is a hepatitis B patient that, a nurse is treating and she has an accidental needle stick, definitely should be receiving treatment for that as soon as possible within 24 hours to increase the chances of not contracting that disease. I'm going to check the chat here. Did you guys want me to go back to the slide again, or are we good to move forward? And then, of course, like I said, if at any point you have any questions, drop them in the chat box and I will get to it because I'm checking on you guys. All right. Awesome. Thank you. So we have some complications here of hepatitis. Some severe outcomes are chronic hepatitis, right? So just having that disease process for a really long time. That can happen with type B, C, and D. Or having cirrhosis, which is fibrotic scarring of the liver, right? Our liver is a very large organ in the body. It's a very strong organ. It, does a lot of elimination and processing, a lot of detoxification for us. It's an extremely important organ. But after it has so much damage to it over time, it can have some scarring and become more stiff and unable to do its job the way that it did before. And that's called cirrhosis. Hepatic encephalopathy, which is when there is increased ammonia in the body because it's no longer able to be eliminated. And when the ammonia in the body rises so much, that can cause a confusion in the patient. The patient can, start to have a lot of different symptoms. And immediately at that point, a very likely intervention would be giving lactulose to the patient so they can eliminate through their feces all that extra ammonia in the body. And another complication here is portal hypertension, which is esophageal varices and ascites, right? So I've had a lot of these liver patients in the progressive care unit that I've worked at. And when the patient is having portal hypertension, they are basically and they're having esophageal varices and ascites. There's like enlarged veins, and the body is just not able to process fluids anymore the way that it was before. So these patients will have, yellowing of the skin. They will have a lot of like swelling, a lot of bloating, a lot of fluid buildup in the body, which we all know fluid overload in the body can lead to lots of other complications. So there's a lot of really big things to assess for and monitor for here in these patients. And another complication can be liver failure or hepatocellular carcinoma, right? So we can have liver cancer as a complication. So an NCLEX tip here, it's really important to monitor patients that have chronic hepatitis for decreased albumin and increased PT and INR and for mental status changes, right? So your patient is presenting with yellowing of the skin and the eyes, pain in the right upper quadrant, they're bloated, they're fluid overloaded. We're going to check their labs. A common finding is going to be decreased albumin and increased PT and INR. And they are going to be having mental status changes if they're having hepatic encephalopathy, which is the increased ammonia, right? And this is actually pretty common with patients that have chronic liver conditions. Let's keep going here. So now let's talk about Crohn's disease and ulcerative colitis. So let's talk about the pathophys and the etiology of this condition here. It is defined as a chronic inflammation of the GI tract, primarily Crohn's disease and ulcerative colitis, which make up irritable bowel disease, right? And it is caused by immune-mediated inflammation that damages the intestinal lining. And it can result in ulceration, which is a damage of the tissue, edema, which is swelling, and malabsorption. And chronic inflammation of the GI tract can lead to scarring, strictures, which is when there's a buildup of scar tissue that causes an obstruction, and increased colon cancer risk. Unfortunately, younger and younger people are starting to show up to the doctors with colon cancer. So this is a pretty serious problem. If you are going to be working in any level of adult health, you will be seeing GI patients like this very often. And the NCLEX tip here is that IBD is different from IBS, right? We talked about this earlier. Somebody asked a question, or they dropped in the chat that that's kind of one of the, more challenging topics when it comes to the GI system here. So IBD is different from IBS, which is irritable bowel syndrome. IBD has structural damage and IBS does not. So I want to show you some key differences here between Crohn's disease and ulcerative colitis, which are the two diseases that we're going to be talking about. First, the location. With Crohn's disease, it can take place anywhere in the GI tract, anywhere from the mouth all the way to the anus. And for ulcerative colitis, it's in the colon and the rectum only. So you're not going to see ulcerative colitis process taking place in the stomach, right? And the depth of inflammation for Crohn's disease is transmural, which is the entire wall. whereas for ulcerative colitis, it's the mucosal and submucosal layer only. And as far as the lesions go, in Crohn's disease, there's patchy areas, also known as skip lesions. Whereas for ulcerative colitis, there's continuous inflammation. There's complications for both. For Crohn's disease, it tends to be fistulas, strictures, and malabsorption, whereas for ulcerative colitis, it's a toxic megacolon and colorectal cancer. For surgery, for Crohn's disease, it's not curative, whereas for ulcerative colitis, it can be curative with colectomy. A mnemonic to remember here is Crohn crashes all GI, UC is limited to colon. So UC is standing for ulcerative colitis. Let's see. Got some questions here. Which type of infection precautions should the patient with Hep B be put under? I do believe it's just contact precautions for Hep B. Yes. And then, hello, can aged processed foods highly cause GERD? Yes. So GERD tends to be not necessarily, those foods can't cause it per se, but they can irritate it and exacerbate the condition. Can hepatitis vaccine be administered when somebody already has hepatitis? Yes, it definitely can. And like I mentioned earlier, if somebody was exposed to hepatitis and they get the vaccine within 24 hours, that can be very helpful to prevent from contracting the disease. I see here what is a stricture, and a stricture is a narrowing or constriction of a structure that's kind of tubular in the body, right? So like I said earlier, if you have like scar tissue building up and it kind of causes an obstruction and tightening of that tubular area. Yeah, so for hepatitis B, contact precautions, make sure you're wearing gloves. And of course, if you're doing some kind of a procedure with that patient that's going to potentially cause a splash of fluids on you, you want to go ahead and, suit up like you would for any other condition. Now, for clinical manifestations, and again, keep the questions coming. I love it. And I'll keep checking in on the chat box as I kind of go between the slides and the chat and answering your guys' questions. So for clinical manifestations, we have some shared symptoms of both conditions here. So diarrhea is a very common symptom of both Crohn's disease and ulcerative colitis. And often in ulcerative colitis, the diarrhea can have blood in it. And that's actually one of the marking symptoms of ulcerative colitis. And as we see here, we also have abdominal cramping, weight loss, fatigue, and fever during flare-ups because it can trigger an immune response in the body, right? Fatigue, weight loss can definitely happen because of the diarrhea, because there's malabsorption. The food is not nutrients aren't being absorbed properly, and lots of abdominal cramping. That's actually a very common one. So Crohn's specific symptoms can lead to pain often in the right lower quadrant. It's not always 100% there, but often when there is pain in the right lower quadrant associated with these other symptoms, that's most likely associated with Crohn's, as well as with malnutrition, vitamin deficiencies. Let's say they're telling you, but I'm eating well, I'm eating a healthy diet, I'm taking vitamins, and we're still seeing vitamin deficiencies in their labs. It's because, they're not absorbing them. And there can also be fistulas and abscesses. Fistulas tend to be kind of an unexpected opening between structures. And abscesses can be, a collection of like pus and like white blood cells and in a very inflamed and like swollen area. And as far as ulcerative colitis specific symptoms, left lower quadrant pain, urgency and tenesmus, and bloody stools are more common, right? So we're going to have a lot more bloody diarrhea when it comes to ulcerative colitis, and that's how you would differentiate the two. And the tenesmus is like a painful, urgent, like urgency to go to the restroom. So if you have a patient coming to you and you're not sure of which one it is, look for these specific symptoms, right? During your assessment, you're going to be asking them questions like, when was your last bowel movement? What was it? Did it hurt? Was there any blood in it? And if it is bloody, it's most likely going to be ulcerative colitis. And an NCLEX tip here is chronic bloody diarrhea plus left lower quadrant pain is a strong indicator for ulcerative colitis. And of course, we're always going to assess, where's the pain? Where's it coming from? Does it radiate anywhere? What's the quality of the pain, right? So by assessing all of those things and doing a really thorough, asking thorough questions and doing a thorough, not only a physical assessment of the patient, but a verbal assessment, right, of them telling you their history and what they're experiencing is going to be really important in the process of understanding what it is that they are suffering from. And then we have some diagnostics here that can be helpful to know if they have Crohn's disease and ulcerative colitis. So a CBC is going to be really important. We're going to look at their red blood cells. We're going to look at their H&H, and that's going to show us if they are suffering from anemia, if they have any chronic bleeding of the GI tract, and leukocytosis, right? So are they having like an autoimmune response? We're also going to look at their CRP and their ESR, which typically tend to be elevated during active inflammation. And we might run some stool tests too, right? We want to know if there's some kind of an infection going on. Do they have a parasite? Is there something else going on in there? So we're going to gather a stool sample. Like, is there a C. diff infection? There's lots of different things that it could be. So we want to rule those things out first. So we may do a stool test if the symptoms are inconclusive, and we want to make sure to see if, it's not something else. We're also going to do a colonoscopy and take a biopsy, right? This is actually the gold standard for diagnosis, but we want to be really careful about doing a colonoscopy, right? As we say in the NCLEX tip here at the bottom, avoid colonoscopy during acute UC flare due to risk of perforation. So if the tissue is extremely flared up, it's inflamed, it's just mad, it's angry, it's going to be really dangerous. We don't want to perforate any section of the GI tract that could cause a whole other life-threatening emergency. So we're going to wait to schedule their colonoscopy until they're not having a flare-up anymore. And then another helpful diagnostic tool is a CT or MRI enterography. And this is actually best for evaluating the small bowel for Crohn's disease. So we have a picture here of ulcerative colitis and what the continuous inflammation of the colon kind of looks like. And then we have some management for these conditions, right? Some of the drug classes that we're going to use are the aminosalicylates, right? It's kind of a tongue twister here. We have lots of drugs that are tongue twisters, so we just got to practice saying them over and over again. Aminosalicylates here are going to be like sulfasalazine and mesalamine, which reduce inflammation of the colon. We're also going to prescribe some corticosteroids. Well, we're not going to, the physician will, but we will administer and educate our patients on them. And a great example of this drug class is prednisone. Prednisone is used during acute flares. And of course, patients don't like taking steroids because they can come with a whole host of side effects. They can cause lots of different things. They can cause discomfort, anxiety, insomnia, hair loss sometimes. It's going to be a bit different for every person. So just make sure that you are, educating your patient enough to let them know what to expect, right? We're not going to hide from them that, hey, this may have some side effects, but in the long run, it's going to help you immensely during your flare ups. And your physician is prescribing this because they know that there is the benefit that's greater than the risk. And we know that taking them safely and adhering to the rules of taking these medications is going to be key to prevent complications. There's also immunosuppressants that may be really helpful, especially when it comes to ulcerative colitis, such as methotrexate. That's a pretty common one, and this can help with long-term control. However, again, there are some risks associated. Anytime you are suppressing the immune system, you are going to educate your patient if there is any sign of infection. If you are on an immunosuppressant and you develop a fever, you want to go ahead and notify your physician right away, right? So if you have a case study, this patient has ulcerative colitis, they were, prescribed methotrexate, and they're showing up with a fever. You want to make sure to let them know, hey, we need to notify the physician right away. We need to check your labs and see if your white blood cell count is elevated and if you're having some kind of an infection. Biologics like infliximab and adalimumab, these are going to target TNF-A for severe cases. And we also have antidiarrheals and antibiotics, right? So like Imodium is an antidiarrheal that may help to kind of manage if that person is having flare-ups, right? They're maybe going out to a party, they know they're going to eat some foods that may be a little bit triggering. Maybe they're going to just constantly have that urge to go. An antidiarrheal might be helpful to them. And of course, antibiotics, if they have developed any type of an infection. But again, this is supportive treatment and it has to be used very cautiously and not long term. Now, an NCLEX tip here for the corticosteroids like prednisone, these are only for short-term use, right? Only during acute flares. It's really important to monitor for infection and hyperglycemia. I'm sure I'm sure you've learned in nursing school or in your practice that corticosteroids can increase blood sugar, right? Immensely. So it's important to monitor for that. And, especially if that patient is taking it for a long period of time, we want them to just take it during their acute flares. And also, again, corticosteroids can suppress the immune system as well. So it's really important to monitor for infection. Any questions? Let's see. Crohn's disease. Let's see here. We know that ulcerative colitis is actually an autoimmune disease in the body, right? So it's dysfunction of the immune system kind of attacking itself in a way. But Crohn's disease can run in families. There may be a genetic component to it, but it's not a congenital disease. Let me know if you have any more questions here. Thank you for asking questions. Sometimes we're thinking of a question, but we don't want to ask. But most times, everybody else is thinking of the same question. So if not for yourself, ask for your peers. All right, so we have some surgical management options here. Typically for Crohn's disease, surgical management is only used for complications. Like if there is a stricture, again, that's when there's like a tubular structure in the body and there's damage to the tissue and scar tissue buildup, and the stricture will kind of be like a tightening of that area, right? And then also for fistulas, like if there's a fistula, if somehow there's damaged tissue and an opening between structures, then we're going to go ahead and have to close that fistula. But there is not any curative surgical management for Crohn's disease, and recurrence is common. So it's going to be best to kind of manage that with lifestyle modifications. And for ulcerative colitis, having a total proctocolectomy is curative, but again, comes with its own host of, life management tips and things that the patient will have to deal with and do in order to cope with that. Sometimes it may require an ileostomy or a J pouch. And an NCLEX tip here is For sudden and severe pain and abdominal distension, we need to suspect a toxic megacolon, which is an emergency caused by ulcerative colitis. And I'll show you a picture here of the proctocolectomy. So they kind of bring out the end of the ileum as an ileostomy, and the anal sphincter is retained, and a colon and rectum are removed. So, talking about some interventions and education here, for anybody who's having an acute flare, we may put them on an NPO diet, which is nothing by mouth, or we may give them a low residue diet, right? We're going to definitely monitor their electrolytes, because they may be dehydrated, right? They may be suffering from a lot of diarrhea, and we know that that can cause
Junior.
these imbalances. Do you guys have any questions? Thought I heard someone say something. Chime in if I didn't hear you, please. I don't mind. And then let's see here. So yeah, so monitor electrolytes. We want to make sure there's no acid-base imbalances here. And we also want to make sure that we check in and monitor their I's and O's, right? Their intake and their output. And this is going to let us know if they are suffering from hypovolemia or hypervolemia, right? Excess fluid or too little fluid. We also want to control their pain and their symptoms, right? So we're going to have some pharmacologic management here and help them with their comfort. And we want to give them a lot of rest and emotional support because this can be a very tiring condition, right? Both of them. They can be very tiring. They can do a lot of, emotional, they can do a lot of damage to somebody emotionally and mentally, right? They may not be able to be in a social setting. They may always be in pain. They may feel terrible about what they can and can't eat, so this can have a really heavy effect on somebody's emotional well-being. So it's important to be supportive of that. And we want to give them long-term education, right? Like, how can you manage your condition over time? For most of these, want to make sure that we let them know to eat high-calorie, high-protein diets, or a low-fiber diet, right? The fiber may be irritating to the colon. And if they're only able to eat small meals, we want those to be high protein and high calorie so that they're getting good nutrition from their food. A lot of times, they may have specific triggers, just like with peptic ulcer disease and GERD. A lot of times it can be dairy, raw veggies, and caffeine. Raw veggies can be a lot harder to digest, so it's a lot more work on the GI tract. And we also want to educate our patients on the importance of adhering to their medications, as well as having follow-ups with the physician, right? Because they may be on some tough medication. They may be on an immunosuppressant, or they may be on prednisone. We want to make sure that they're following up, right? That we're checking their labs, making sure they're not chronically anemic. We're making sure they're not suffering from any infections. And we want to make sure that they're adhering to their medications that are necessary so that they're not, suffering from any of the symptoms that can take over their lives. Or, if, for example, if they're taking antibiotics due to a secondary infection caused by, the condition, then we want to make sure that they're adhering to that so that they're completing their course. And we want to monitor for complications, of course. We want to monitor, make sure that there's no bleeding, there's no perforation. And what if they're having a lot of weight loss because they're not able to eat, or they're having too much diarrhea or malabsorption issues, right? We want to make sure that we're following up and monitoring. So this is going to be a very important part of our education. And as an NCLEX tip here, during remission, it's important to focus on nutritional support and preventing flare-ups. I'm going to go very quickly over strategies for test taking here. I went over this in my last one, and I'm probably going to put a little highlight of this in all the meetings that I, provide, all the webinars that I provide, I'm going to talk a little bit about some strategies to look for and to use when you're taking a test, when you're taking the NCLEX, and when you're doing your practice questions. And this is just some images that I have here showing a couple of the most common strategies to use when it comes to prioritization questions. And it's going to be your ABCs and your Maslow's hierarchy of needs. And I'm going to talk a little bit about some of those strategies here. So one of the strategies I really like to use is the elimination strategy. Sometimes when I look at a question and I see the options, there's some options that are immediately screaming out to me like, nope, that's not it. And I know that they're irrelevant to the question, or they're talking about medication that's, completely irrelevant to the condition. So I'm going to go ahead and eliminate those options, right? And eliminating the wrong answers can actually increase your chances of selecting the correct answers by removing obviously wrong choices. And the way that you use it is to eliminate answers that contradict medical facts. You're going to also remove distractors, choices that are partially correct but don't fully address the question. You'll see that a lot on the NCLEX, and it's going to be distractor answer options, right? You see A, B, C, D, and E all look correct, right? But there's one that's the most correct. One of them is maybe just partially correct. Maybe the other one is not even addressing the question at all, right? So it's going to be really important to take a look at those and be like, you know what, I'm eliminating that so I can pay attention to what matters here. And then you also want to avoid absolute terms. If you see an answer option that says always or never, that's typically not going to be the right answer, unless, of course, it's clinically justified to say always or never, right? So I guess an example of that could be like, if you say always finish your antibiotics, right? You always want to finish your antibiotic course. We know that that's a clinically justified use of absolute terms. And another strategy that I like to use is prioritization. So when you have prioritization questions, you want to use some of these strategies, such as the ABCs or Maslow's hierarchy of needs, or thinking about the nursing process, such as ADPI. And we'll talk about that right now. When it comes to the ABCs, this is the most common one. I'm sure you're familiar with it. And it stands for airway, breathing, and circulation. So for airway, we want to ask ourselves if the airway is open and clear, right? Is there any obstruction of the airway? Whether it's a positioning obstruction or if it's an actual obstruction of something in the airway. When it comes to breathing, we want to ask ourselves, is the patient breathing effectively? The rate, the effort, right? We want to look at their ventilation status. And also circulation. Is the heart pumping oxygenated blood, right? Want to look at, their blood pressure, things like that. And we'll kind of go through that as we do our practice questions. And then NCLEX tip here is if a question is asking you what to do first, always prioritize the airway first unless another option is more life-threatening. So sometimes there are other options that are more life-threatening, but as long as it's relevant to the question, always look at the answer options, and in that order, airway, breathing, and circulation. That's how you would prioritize it, unless something else is more relevant to the question or it's a lot more life-threatening than the airway option. Now, for another strategy here, Maslow's hierarchy of needs, which was the triangle that was in the previous slide, we want to prioritize physiological needs first, always. Oxygen, food, water, and elimination, right? So if it's telling you like you have 4 clients, one of them wants you to give them gloves. One of them is asking questions about their medication. One of them wants to talk to you about how they're sad. And one of them needs to use the restroom. Which one are you going to help first? And it's going to be the one that needs to use the restroom, right? Because that's a physiological need. That person needs to use the restroom. If we don't help them use the restroom, they may get up on their own and they may be a fall risk at this point, or, there may be other complications. But we want to prioritize physiological needs above the other needs on the pyramid. And the second priority would be safety and security, which is Examples here: fall prevention and infection control. And third priority, love, belonging, self-esteem, and self-actualization. So like I said before, maybe like emotional needs. Now, an NCLEX tip here is physical needs always come first before emotional or psychosocial concerns. And the last one here I want to talk about is the nursing process, which is also known as ADPI as a mnemonic, with A standing for assess, D for diagnose, P for plan, I for implement, and E for evaluate. So you always want to gather data before you intervene, unless the situation is emergent, right? So if you have a question asking you what you should do first about something, you should always assess first. However, if you have a life-threatening situation, then you really want to make sure to take care of that before you assess that patient, right? You want to make sure your patient is alive so they can be assessed. So always take care of any life-threatening stuff first. And then after assessing would be identifying the problem and then determining the best course of action. And then after that, you would carry out your intervention and check if your intervention worked, right? In some of the case studies, you may see questions like that will say, like, list which symptoms show that this intervention worked. Did their fever resolve? Did their blood pressure improve, right? So an NCLEX tip here is if a question is asking you, what should the nurse do first? Make sure that you choose the assessment action unless you need to have immediate intervention. Not seeing any questions here, but please feel free to chime in if you need to. And let's go ahead and get into our practice. So I'm going to read a question to you, and we're going to do about 10 questions, and then I'm just going to give you like a minute or two to answer the question. You're free to chime in vocally if you want, or you can just drop your answers in the chat box, and then I'm going to go through each answer rationale and let you know why it's wrong and why it's right. So this one is: a nurse is assessing a client with a suspected duodenal ulcer. Which manifestation is most characteristic of this condition? We talked about this earlier. A, epigastric pain that worsens with food intake. B, hematemesis without prior discomfort. C, burning epigastric pain relieved by eating. Or D, nausea and vomiting as the primary symptom. So which one is it? Everyone is saying C. So let's go ahead and take a look at the answer. I see you guys seem confident about it, and as you should, because you're correct. So the reason why the answer is C is because typically burning epigastric pain relieved by eating is a hallmark symptom of duodenal ulcers, right? We talked about it earlier in our slide when we were talking about PUD. We know that the temporary relief occurs because the food actually buffers the gastric acid. So this helps to reduce the irritation of the duodenal lining that has the ulcer in it. And duodenal ulcers typically present with burning epigastric pain that improves with food intake. So the pain usually does return, though, about 2 to 5 hours after eating or during the night when the stomach is empty. The reason why A was incorrect is because epigastric pain that worsens with food intake is more characteristic of gastric ulcers. And that's because food increases acid secretions, right? The body wants to digest it, so it actually worsens the pain. B, hematemesis without prior discomfort can actually occur in severe ulcer complications, but it's not the most common initial symptom of a duodenal ulcer. And nausea and vomiting as the primary symptom are a lot less common in duodenal ulcers, but they can occur if there's a case of severe obstruction or complications. So the key takeaways here are that duodenal ulcer pain improves with food and recurs hours later when the stomach is empty. And gastric ulcers worsen with eating, unlike duodenal ulcers, right? And that's because of the positioning of where each ulcer is. And another takeaway is that H. pylori infection and excessive acid secretion contributes to duodenal ulcer formation. Let's do another question. A nurse is assessing a client with a suspected perforated peptic ulcer. Which intervention should the nurse anticipate? Prepare the client for emergency surgery, administer an antacid, insert a nasogastric tube for gastric decompression, or obtain a prescription for a proton pump inhibitor. Now, the last question was more determining what our base knowledge of ulcers was, right? But this one is, the question is asking what the nurse should anticipate, right? Which intervention is going to be more relevant to the condition that we're talking about here? And we're talking about a suspected perforated peptic ulcer. We don't know yet, but we also know that perforation is a very serious life-threatening emergency, right? So we always want to re-ask ourselves a question and see what is it really asking. So let me see what your guys' answer options are here. I'm seeing a lot of A's. All right, let's take a look here. See if you got it correct. And you are correct. I see you guys are paying a lot of attention and you are putting your thinking caps on and translating all that knowledge into practice. And that's what's going to be really important on this test. So we see here that a perforated peptic ulcer is a medical emergency and it does require immediate surgical intervention in order to prevent peritonitis and sepsis, right? Peritonitis is an infection of the peritoneal cavity, and sepsis is when that infection causes multi-organ failure. Now, the perforation allows gastric contents to leak into the peritoneal cavity, leading to severe abdominal pain, guarding, and signs of shock. And we talked about this earlier as well when we were talking about complications of peptic ulcer disease. So the rationale for the answer is that answer A tells us preparing the client for emergency surgery is the priority intervention, and that's because perforation is life-threatening, and it will require surgical repair to close the ulcer and prevent further complications. Now, the reasons why the other answers were incorrect was administer an antacid is not appropriate in a perforated ulcer, right? What is an antacid going to do? It's not going to do anything. You need surgery to close that. So we definitely need surgical intervention rather than acid neutralization. And inserting a nasogastric tube for gastric decompression could be a part of the preoperative care, but it does not treat the perforation, right? So that could be something that we could do. We're going to put in an NG tube, put it on low suction so that it can, remove the acid, but it's not going to fix that immediately life-threatening complication. And obtaining a prescription for a PPI can be useful for peptic ulcer disease, but it also does not address the perforation, right? That requires immediate surgical repair. So some key takeaways here are that perforated peptic ulcers require emergency surgery, and they're preventing peritonitis and sepsis. When you have severe abdominal pain, rigidity, and signs of shock, that can indicate a perforation. And acid suppression, such as PPIs and antacids, that would be an insufficient strategy for a perforation because surgical intervention is necessary. So let's do the next question here. A nurse is assessing a client with suspected ulcerative colitis. Which finding is most characteristic of this condition? A cobblestone appearance of the intestinal mucosa, skip lesions affecting the entire gastrointestinal tract, continuous mucosal inflammation starting from the rectum, or malabsorption due to transmural bowel involvement. This is a great question. We talked about the differences between Crohn's disease and ulcerative colitis. So we know that in this question, the nurse is assessing the client and they don't know yet. They think they may have ulcerative colitis. So they're looking for a characteristic finding that's associated with the condition the most, right? So this is testing our base knowledge here of the condition. And let's see what you guys are saying. I'm seeing A's and C's. Let's go ahead and take a look at the answer here. So the correct answer was C. So we know that UC is characterized by continuous mucosal inflammation that starts in the rectum and extends proximately through the colon, which is unlike Crohn's disease. Ulcerative colitis actually affects only the mucosal and submucosal layers, and it does not have skip lesions, right? So our answer was C, which is continuous mucosal inflammation starting from the rectum. We know that this is actually the hallmark of the condition. And the disease actually progresses in a continuous pattern without skipping areas. And it leads to symptoms like bloody diarrhea, abdominal pain, and urgency. Now, the rationale for the incorrect answers here, the cobblestone appearance of the intestinal mucosa is actually a characteristic feature of Crohn's disease, not UC. Skip lesions affecting the entire GI tract occur in Crohn's disease also. And ulcerative colitis actually involves only the colon in a continuous pattern, whereas Crohn's disease has affected segments that are interspersed with healthy bowel. So there's some segments that are affected, some healthy bowel, some affected. And then option D was incorrect, malabsorption due to transmural bowel involvement. And that's because this is also seen in Crohn's disease, which affects all layers of the bowel wall, whereas ulcerative colitis only affects the mucosal and submucosal layer and leads to bloody diarrhea, but not significant malabsorption. So your Crohn's disease patients are going to have a lot more weight loss because of the malabsorption. Some key takeaways are that UC involves continuous inflammation starting at the rectum and extending proximally, which means inward. And Crohn's disease has skip lesions, which means they skip healthy bowel. And they can affect the entire GI tract with transmural involvement, which means all the layers. And bloody diarrhea, urgency, and abdominal pain are actually common symptoms of ulcerative colitis. You guys are doing a great job. We have a few more questions to get through here. A nurse is providing education to a client with Crohn's disease about managing the condition. Which instructions should the nurse include? Select all that apply. Follow a high-fiber diet, increase fluid intake, consume small, frequent meals throughout the day, avoid all sources of dietary fat, and take NSAIDs as needed for abdominal pain. Very interesting. So let's reread the question. We know the question is asking us about providing education, right? So we have to provide correct education here. We can't provide things that are unexpected or things that are incorrect. And the education is about managing Crohn's disease. So it's asking what instructions should we include, right? And since it's a select all that apply question, I'm going to go ahead and look for answers that are only entirely true, right? Because if the answer is partially true but partially false, it's not going to be a correct option. So I look at select all that apply answer options as true or false, basically. That's the way I do it, and it has been very effective for me. So let's take a look at these answer options here and see what you guys think it is. I'm getting lots of C's. A, B, C, A, C, B, C, D. And you guys are definitely on the right track here because B and C are the correct answers. So the rationale for the correct answers here are that increasing fluid intake and consuming small frequent meals throughout the day are going to be the best interventions for Crohn's disease because proper dietary management is essential in order to reduce symptoms and prevent flare-ups. Increased fluid intake helps to compensate for fluid loss from diarrhea, and small frequent meals are easier to digest and help to minimize GI distress. We know that Crohn's disease often can lead to dehydration and electrolyte imbalances because of the diarrhea, so that's why we increase fluid intake, and we need adequate hydration to prevent complications here. And we know that reducing the digestive burden on the bowels that are inflamed are going to help minimize symptoms such as pain and bloating. So that's why it's good to educate our patients on consuming small, frequent meals. Now, following a high-fiber diet is incorrect because high-fiber foods can actually exacerbate symptoms, especially during flare-up, and they can increase bowel irritation because fiber increases motility of the bowels that can cause the bowels to be more irritated, right? And it can cause more diarrhea. And avoiding all sources of dietary fat is incorrect because moderate fat intake is actually recommended, right? But these patients should be limiting their high-fat foods, right? Like fries and things like that, especially if they trigger symptoms. And option E, take NSAIDs as needed. Well, we talked about NSAIDs and their effect on the GI tract. So this is definitely incorrect because they can worsen inflammation in the GI tract and they can increase the risk of ulcers and bleeding, right? So if you know your patient has an ulcer, they have GI irritation, we're going to administer acetaminophen, not an NSAID. So if you know your patient has an ulcer and your physician orders an NSAID for their pain, you're going to question that order, right? You're going to call your physician up and say, hey, this patient actually suffers from a peptic ulcer, and, it'd be much better if we could give them acetaminophen instead. Always, always advocate for your patients. So our key takeaways are that increased fluid intake is essential to compensate for diarrhea-related fluid loss, and small frequent meals help to prevent digestive overload and minimize symptoms. And high-fiber foods and NSAIDs should be avoided to reduce the risk of symptom exacerbation. Let's go ahead and look to the next question here. A nurse is providing discharge teaching to a client diagnosed with a hepatitis B virus. Which statement should be included in the teaching? So another education question here. Select all that apply. You should avoid sharing personal items like razors or toothbrushes. Consuming alcohol in moderation is safe with hepatitis B. You can donate blood once your symptoms resolve. Close household contacts should be vaccinated against hepatitis B. And you should stop taking all medications until your liver function normalizes. Looks like my slide got messed up here. Option D is connected to option C. Sorry about that. But let's think about the hepatitis B virus. We're providing discharge teaching, right? So this education needs to be something that's going to last a long time for this patient, right? This patient needs to know these things in order to prevent further complications and in order to manage their condition. So which statements are we including in their teaching? Let's see what you guys are saying here. I'm seeing A and D. A and D. Let's take a look. And we also want to think about the transmission route of hepatitis B, right? So you guys are correct. The answers are A and D. And that's because hepatitis B is a bloodborne and blood fluid transmitted viral infection, and it can cause liver inflammation and long-term complications. So these patients need to prevent transmission and protect their close contacts, right? These are key components of our discharge teaching. So option A was hepatitis B virus is transmitted through blood and body fluids. So personal items that may be contaminated with blood, such as razors and toothbrushes, should not be shared to prevent the infection, right? So, toothbrushes, because there are little micro abrasions being done to the gums when they're brushing their teeth. So there may be blood residue on their toothbrushes, and also razors, micro cuts in the skin can be infected with the blood. And so if they shared those, that could spread the infection potentially. And then D, vaccination is the most effective way to protect close contacts from hepatitis B. So household members and sexual partners should be screened and vaccinated if they are not immune, right? So that's our rationale here for option A and D. And option D was close household contacts should be vaccinated. Just going back so you guys can read what it was. And then our rationale for the wrong answers are going to be B, alcohol should be completely avoided because it exacerbates liver damage and it increases the risk of cirrhosis and liver failure in clients with hepatitis B. And we talked about how when our liver is healing from an infection or a chronic condition of any sort, we should not further exacerbate it by giving it an extra load of work and consuming hepatotoxic chemicals such as alcohol. Option C, hepatitis B can cause a chronic carrier state. An infected individual should never donate blood as the virus can still be transmitted even if symptoms subside. And option E, not all medications need to be stopped, but clients should consult their healthcare provider before discontinuing any prescribed medication, as some may be necessary for managing comorbid conditions. So the key takeaways here are that hepatitis B spreads through blood and bodily fluids, and personal hygiene items should not be shared. Close contacts should receive the hepatitis B vaccine to prevent infection, like we talked about earlier. If anybody is being exposed, then vaccine should be, one of the interventions. And alcohol should be strictly avoided, and blood donation is not permitted for individuals with hepatitis B. Another question here, nurses reviewing risk factors for hepatitis A virus infection with a group of clients. Which of the following are risk factors for contracting the disease? Select all that apply. Consuming contaminated food or water, receiving a blood transfusion, traveling to areas with poor sanitation, intravenous drug use, and unprotected sexual contact with multiple partners. So let's think about our base knowledge of hepatitis A virus. What's the transmission route? We're educating a group of clients here on the risk factors, right? So we want to make sure that we let them know the correct risk factors. Let's see what you guys are saying. A and C. Lots of A and C here. Let's look at the answer. You're correct. You guys paid a lot of attention. I love it. So the hepatitis A virus is primarily transmitted via the fecal-oral route, often through contaminated food, water, or poor sanitation. So travelers to areas with inadequate hygiene and sanitation are at increased risk. Our rationale for answer A is that hepatitis A is commonly spread through ingestion of food or water contaminated with infected feces. And this happens particularly in areas with poor sanitation or improper food handling. And our rationale for option C is that travel to regions with inadequate sewage that's available and water treatment increases the risk of hepatitis A exposure because of contaminated food and water sources. So if their sewage isn't adequate, or if they don't have proper water treatment that takes care of, sanitizing their water, their risk is definitely increased. Now, the reason why the other answers were incorrect, unlike hepatitis B and C, hepatitis A is not bloodborne and does not spread through transfusions. Remember, it's a fecal-oral route. And while IV drug use increases the risk of hepatitis B and C, hepatitis A is not typically transmitted through blood or needles, which we just said. And also, it's not a primarily sexually transmitted infection. However, certain sexual practices involving fecal oral exposure may pose a risk. Some key takeaways: hepatitis A spreads via fecal oral route, often through contaminated food and water. Travel to areas with poor sanitation can increase the risk. And it's not transmitted through blood transfusions or IV drug use, unlike B and C. Now, nurses caring for a client with peptic ulcer disease, which complications should the nurse monitor for? Select all that apply. Perforation, pancreatitis, gastric outlet obstruction, appendicitis, or cholecystitis. So let's think about our base knowledge and jog our memory here. Peptic ulcer disease does have, we think about like the anatomy and physiology of it, and we think about the disease process and what complications can come from that, right? And since it's select all that apply, we're going to go ahead and only choose the answers that are entirely correct. So we have A and C popping up here. And you guys are absolutely correct. You're doing such an awesome job. I love that. You guys are really putting your thinking caps on. And we know that PUD can actually lead to serious complications, right? And some of those would be perforation and gastric outlet obstruction. And these conditions require prompt recognition and intervention in order to prevent life-threatening consequences. So our rationale here is that a perforated ulcer can occur when the ulcer erodes through the stomach or the duodenal wall, right, all the way through, and then it leads to sudden severe abdominal pain, peritonitis, and signs of shock. This is definitely a medical emergency, and it requires immediate surgery in order to fix the perforation. And chronic inflammation and scarring from ulcers that are recurring can cause gastric outlet obstruction, right? This can lead to vomiting, early satiety, and abdominal distension due to delayed gastric emptying. Now, the reasons why the other answers were incorrect are because pancreatitis is typically caused by gallstones or alcohol abuse, not by peptic ulcers. But a penetrating ulcer can extend into the pancreas. However, this is a rare condition. And appendicitis is an actually unrelated condition, and it's caused by an obstruction of the appendix, which leads to infection and inflammation and often surgery to remove it. And cholecystitis is usually called by gallstones, not peptic ulcer disease. So you guys did an awesome job answering all the questions so far. Some key takeaways is that perforation is always a life-threatening complication and it requires emergency surgery. And gastric outlet obstruction can occur due to scarring and inflammation, and it leads to delayed gastric emptying. Now, pancreatitis, appendicitis, and cholecystitis are not direct complications of peptic ulcer disease, and they have different etiologies. Another question here, nurse is assessing a client with ulcerative colitis who reports frequent diarrhea and abdominal pain. Which assessment finding requires the nurse's immediate intervention? Blood-tinged stools with mucus, mild abdominal distension after meals, a serum potassium level of 2.9, or cramping relieved by defecation. Now we know that we're talking about ulcerative colitis here. This client is reporting frequent diarrhea and abdominal pain. So we're looking for a finding in our assessment that is going to require immediate intervention. So this is a prioritization question. And we can use our ABCs here, and we can also use our Maslow's hierarchy of needs too. And we're going to look for a assessment finding that is going to potentially be life-threatening, right? Because it's asking for immediate intervention. So what do you guys think? Option C is what I'm seeing here. And you're correct. And that's because a serum potassium level of 2.9 indicates hypokalemia. This is potentially life-threatening. It is an electrolyte imbalance. You know that potassium has a lot to do with your cardiac balance. So clients with ulcerative colitis are at risk for fluid and electrolyte depletion because of frequent diarrhea. And a potassium level of 2.9 can lead to cardiac dysrhythmias, muscle weakness, and hypotension, and they will need immediate intervention such as potassium replacement and fluid resuscitation. So hypokalemia can occur due to excessive diarrhea and can cause life-threatening cardiac complications. And as the nurse, you should notify the provider immediately and anticipate supplementing potassium. Now, the other answers were incorrect because blood-tinged stools with mucus, these are expected with UC, and they can happen because of the mucosal inflammation, but they don't require immediate intervention unless there's massive bleeding, right? And we also know that some bloating can occur due to gas production and inflammation, but this is not actually an emergency unless there's signs of obstruction or severe pain. And cramping relieved by defecation is actually another common symptom that happens with ulcerative colitis, and it doesn't indicate a severe complication. So some takeaways are frequent diarrhea and UC can cause electrolyte imbalances. And hypokalemia requires urgent intervention because we want to make sure that we're preventing cardiac arrhythmias and muscle weakness. And blood-tinged stools and mild bloating and cramping are actually common findings, but they're not emergencies unless they're severe, really sudden, or they're worsening, right? And we know that with the NCLEX, they are going to try to trick you with common findings versus findings that actually require immediate intervention. Now, a nurse is caring for a client with fulminant hepatitis. Which intervention is the priority in managing this condition? Administering lactulose, monitoring for signs of increased intracranial pressure, administering vitamin K, or preparing the client for possible liver transplantation. What do you guys think? I'm seeing A in the answers here. So we know that we're dealing with hepatitis, which is the liver. So let's jog our memory about, some of the complications that can come with that and see how relevant these answer options are to the condition that we're talking about. We're talking about a priority intervention here. So let's take a look. And the correct answer was option B, actually, and that's because ammonia accumulation of hepatic dysfunction can cause cerebral edema. Remember, we talked about when ammonia accumulates in the body, it can cause ascites, which is, a fluid overload, right? And so this can actually lead to altered mental status, confusion, lethargy, and eventual coma. So we need to monitor their neurostatus closely, and we need to detect early signs of ICP to prevent brain herniation. And here's a really good, confusing kind of answer choice, right? We looked at lactulose. We all kind of thought it was lactulose. So we know that while lactulose is used to treat hepatic encephalopathy because it reduces serum ammonia, it does not actually directly prevent or manage cerebral edema, right? We were talking about the most urgent concern here. So option C, liver failure leads to impaired clotting factor synthesis, but correcting coagulopathy is secondary to preventing cerebral edema, which is the primary life-threatening complication in this case. And liver transplantation is definitive treatment for fulminant hepatitis. However, immediate intervention is needed to manage complications such as cerebral edema before a transplant can occur. So some takeaways are that fulminant hepatitis can cause rapid liver failure that leads to cerebral edema and increases ICP, which are the most life-threatening complications. And we need to monitor their neurostatus as a priority to detect early signs of cerebral edema, including altered mental status, confusion, and coma. And other interventions such as lactulose, vitamin K, and liver transplantation are very important. However, they're not the immediate priority over preventing brain herniation. Another question we have here, nurses caring for a client prescribe multiple medications, including isoniazid and acetaminophen. Which assessment finding requires the nurse's immediate intervention? Dark urine and jaundice, abdominal discomfort after meals, fatigue and dizziness, or occasional headaches and nausea. So we know that this client has been prescribed multiple medications, including isoniazid and acetaminophen. So this is jogging our memory. Let's think about what conditions can be associated with these medications, right? And kind of see which assessment findings and the answer options are going to be relevant and which ones are going to be the most important, right? It's a prioritization question here. So which one of these findings are going to require immediate intervention? What do you guys think? I'm seeing option A a lot, dark urine and jaundice. So let's take a look at the answer. And you guys are correct. So isoniazid and acetaminophen are both hepatotoxic drugs, meaning they can cause liver damage or failure. And we know that dark urine and jaundice, which is yellowing of the skin and the eyes, suggests liver dysfunction, and that requires immediate intervention to prevent progression to acute liver failure. So, dark urine and jaundice are classic symptoms of hepatitis or acute liver failure, and immediate intervention of liver function tests and discontinuation of hepatotoxic medications may be necessary. We know that acetaminophen and isoniazid are hepatotoxic. So option B here was incorrect because abdominal discomfort after meals can actually occur due to other causes too, right? So some of these causes can be like gastric irritation, but it's not an immediate concern unless it's severe, sudden, or persistent, right? And also coming along with other symptoms. And we know that fatigue and dizziness are non-specific and they can actually be caused by multiple factors, right? This person can have anemia, dehydration, or they can even be having side effects of certain medications that they're taking, but this doesn't actually directly indicate acute liver failure. And we also know that occasional headaches and nausea are common medication side effects, and they do not indicate severe liver dysfunction requiring immediate intervention. So some takeaways here are that isoniazid and acetaminophen are hepatotoxic. So always learn your drugs and do lots of time on your pharmacology to understand the effects of different drugs, right? And hepatotoxic drugs can cause severe liver injury. And we also know that jaundice and dark urine are critical signs of liver dysfunction and they require immediate intervention. And other symptoms like dizziness, headache, and mild abdominal discomfort are less urgent, but they should still be monitored, right? We don't know if they're still being caused by other conditions or if they're related to what we're dealing with here. So those were all our practice questions for today. I'm going to do a conclusion here. And if you guys have any questions, go ahead and drop them in the chat while I kind of go over what we went over today. So some key takeaways are for peptic ulcer disease, it's caused primarily by H. pylori and NSAIDs. And it's important to prioritize acid suppression, do antibiotic therapy, and recognize GI bleeding or perforation. We also know that GERD is due to LES dysfunction. And if you remember, LES stands for lower esophageal sphincter, and it's also due to acid reflux. It's important to focus on lifestyle changes and pharmacologic therapy such as PPIs and H2 blockers such as Protonix and Pepcid, and prevention of esophageal complications. And we also remember that hepatitis, it's important to know the transmission, the serology, and the vaccine status of each type from A through E. It's also important to know that chronic forms, B, C, and D, require monitoring and long-term management to prevent cirrhosis or liver cancer. We also know that for IBD, Crohn's, and ulcerative colitis, these both involve autoimmune GI inflammation. It's important to understand the location of disease and the symptom patterns, as well as to know the diagnostic workup and the step-up medication approach with corticosteroids, immunosuppressants, and biologics. And remember on the next gen NCLEX, some strategy tips that we talked about. Prioritize safety and complication prevention, such as perforation, toxic megacolon, or encephalopathy. Always know when to assess, intervene, educate, or escalate. Recognize lab patterns such as increase AST and ALT for liver, decrease H&H, which is hemoglobin and hematocrit for bleeding, increase ESR and CRP for increased inflammation, and positive stool markers to rule out infection. And remember to support your patients with long-term disease by using EBP, which is evidence-based practice, and patient-centered care, right? So such as like lifestyle modifications, and apply all of those to the individual patient that you are treating. So thank you so much for coming to this presentation. I'm really glad to see all of you guys made it, and I'm excited to have presented this topic to you. Thank you so much. Thank you so much for your positive feedback. I really appreciate it. And I'm actually going to drop a link here in the comments for you guys if you want to go ahead and leave some feedback about the presentation and see if if you enjoyed it, if it was helpful. Let us know what you feel about it. And, keep practicing. That's really going to be key here for your success on the NCLEX. It's going to be for you to keep practicing questions and, just getting accustomed to your strategies and like how to approach each question. You guys will get more and more confident the more that you practice, and you're going to do amazing. Thank you so much. I really appreciate your guys' feedback. This makes my day, and I'm happy to have been able to break down this topic for you guys. So the slides, so right before you jump into the presentation, there's actually a link on the presentation or near where the presentation is that lets you know that you can download the slides. So the slides are uploaded prior. You can go on there and download them and, follow up with the slides as I'm showing them to you guys. You can follow through on your end too. They'll be available on the website. So, and again, there's also going to be a recorded link.
Please, I have a question. Where do we access the recorded link?
So we actually answered that earlier, and I'm glad that you asked again, actually, because a lot of people may not have seen the answer when we talked about it, but it is going to be posted on the Naxlex website. Let me go back here to what we said. We'll see. The recordings will be uploaded in the Naxlex website, so you can access it through the app and the web browser, and they will be uploaded for you, so you can download it or watch it again.
Thank you.
You're very welcome, and thank you for coming, for being here, and for taking this time to prepare yourself. It was a pleasure preventing this for you guys, and I'm really glad to have seen you all here. Thank you for sharing all your questions. And I'm really, I'm honored. And I hope to see you guys again, because I'm going to be presenting twice a week on different topics. So come back and sign up next week so you can be well prepared. Thank you guys so much. You are free to go. I'm going to go ahead and end the webinar here. But again, it was such a pleasure. Keep practicing, and I will see you next week if you sign up for some more webinars.
You did a great justice to this. Thank you very much. You did a great justice.
Thank you so much. Much appreciated. I appreciate that feedback immensely. And feel free to leave your feedback on the link that I dropped in the chat too.
Yeah,
Thank
done.
you, guys. Good luck. Your exam is in 2 weeks. Oh my goodness, you're going to do amazing. Good luck. You guys got this. Remember to be confident and trust yourself.
I still can't get the link where you said sending slide. Are you sending it from?
Say that again. I couldn't hear you.
The slide, the presentation. How do we get it? The presentation you did.
So sorry. It sounded a little bit far away. I couldn't understand you. Can you type it out for me?
I said, how do we get the presentation you presented today?
Oh, yeah. The presentation. Yeah. Thank you for asking. So the presentation will be available on the Naxlex website. Yeah. So you can just log in on there and you should be able to rewatch it. It was recorded. So yeah.
Great.
Yeah, absolutely. And then when you come in onto the link beforehand, you will see that it says download slides, so you guys can get the slides as well before the presentation and follow along.
Thank you.
You're very welcome. And I see Corinne here said last time you sent us PDF and we downloaded. Yeah, so the slides are available on the website, so you will be able to download it from there. I'm going to go ahead and say goodbye to you guys for now. Again, it was such a pleasure. Thank you so much for all of your positive feedback. And I really enjoyed breaking down this topic for you. And we will go ahead and see each other on the next presentation. Have a wonderful day or night, whatever time zone that you may be in. And also have a wonderful weekend. Bye, you guys.